All right, good morning, everyone. We're going to get started. I'm thrilled to welcome two fantastic speakers today, Dr. Al Liu and Dr. Ayesha Appa. Dr. Al Liu is the Director of HIV Prevention Intervention Studies at the San Francisco Department of Public Health and a provider at the Healthy Access Point at Ward 86. That's actually in the lobby of Ward 81. The Healthy Access Point provides low barrier care for people with and without HIV, including services like STIs, Hep C, and PrEP. And Dr. Ayesha Appa is an assistant professor in our division. Dr. Appa is an infectious disease and addiction medicine physician and the clinical lead of the HAP at Ward 86. Their talk today is an open door for people who use drugs, low barrier HIV prevention in the HAP. So thank you both for being here, and let's give them a warm welcome.
Thank you so much, Liz. If we had gotten our act together, our photo would have had an actual open door. It is a figurative open door that we have at HAP. Al and I are thrilled to talk with you today and really go through a number of cases that will, I think, illustrate sort of our what's top of mind for us at HAP this year. Here are disclosures. And because we wanted to just stir the pot early and get everybody awake, we're starting with a spicy question for you all. And that is, our nut to crack in HAP is how we deliver PrEP to people who use drugs. So I want you all to log into Poll Everywhere and think honestly about, whether this is in the inpatient setting, on an ID consult, in the clinic, seeing a person with a substance use disorder, is it a clinical priority for you to start PrEP in someone who uses drugs? Would you say A, no, honestly, because usually there's some other urgent need that's coming up, whether it's substance use disorder treatment, START, housing, Hep C treatment, et cetera? Is it B, yes, Ayesha, this is HIV grand rounds. HIV prevention is our big ticket concern. Or C, I don't know. It depends. I allowed people the it depends option. Can this go through? Okay, fantastic. This is a great spread, which honestly, I think really reflects, as our spread is changing, really reflects the reality, the clinical realities that we all contend with of, yes, people have competing priorities and urgent concerns, particularly when we're talking about severe substance use disorders and someone experiencing homelessness. And also, yes, HIV prevention is an incredibly important tool that we're obviously very committed to. So let's hold this with us as we move through the talk. So brief review of what is HAP. I talked about this last year, so I will be quick about this, but thanks to Shep at the SFDPH, the HAPs are 7 different nodes of low or essentially stigma-free access points for testing for HIV, Hep C, STIs. And our HAP is the one that's based in a clinical site and is focused on people who use drugs and people experiencing homelessness. Our model is drop-in, so no appointments, open every afternoon, 1 to 5, is status neutral, as Liz mentioned, and is nurse-led. Our nurses, heart in the back, are the heart and soul of our program, and really sort of manage the triage and drive many of the clinical priorities that we address. We do integrated HIV, Hep C, STI screening, treatment, and substance use disorder services. And we use incentives for testing that we'll talk about a bit more later on in the talk. We, as I shared last year, in the early days, there was not a lot of traffic through the HAP. A question was, are people who use drugs interested in PrEP, and how are we going to drive volume? I will say we have now, I think, after honing a model, working on our partnerships and sort of thinking structurally about how we bring people in and keep folks, volume is not the problem. We've now seen over 450 people between early days in August 2023 and the summer, June 2025. People are primarily finding us through peer referrals, so word of mouth, encounters for safer use supplies, including safer smoking, and then many referrals from primary care for PrEP as well. I'll just say I put this like, this has been a journey because again, I don't want to frame this as we opened the doors and then there were floodgates and everybody rushed through. But again, sort of a thoughtful experience of how do we create this opportunity for people who use drugs to access PrEP. So along these lines and sort of taking off our first audience response question, another one for you, which is what proportion of patients in HPTN 094, and I'll tell you about what that is, were on PrEP at the end of the study. So HPTN 094 was a multi-site trial looking at looking to enroll people who inject drugs with opioid use disorder. And the participants were randomized to either sort of a treatment as usual, which was navigation to services, or mobily delivered integrated services, including PrEP, harm reduction, OUD treatment delivered on a van in a really optimal setting. And these results, these data were presented at CROI this past year. And so I'm curious whether you think that at the end of the study for the people not living with HIV were over half of people on PrEP, was it 15 to 20%, 5 to 10%, or less than 5%? I'm gonna move through because we have a lot of ARS questions quickly. We have a really nice spread and a lot of optimism. I love it. The answer to this question was less than 5%. So it was between 3 and 5%, 4%, 17 out of 409. And you know, there are a lot of studies coming out of this trial, but I think that my top line sort of take home message that I'd highlight is that ease of access is necessary, but not sufficient. There was a really nice qualitative paper that looked at other factors that participants identified in this trial that included risk perception, as well as the need for meeting other needs, as we discussed sort of in that first question: housing, financial stability, care for urgent medical conditions to promote PrEP utilization. And I think really what these data resonate with what we see locally. These are courtesy of the NHBS team and Aaron Wilson in cohort of people who inject drugs, and this is in San Francisco specifically. You can see here that the awareness of PrEP has been sort of hovering around half of people who inject drugs, and really sort of falls off from there with, you know, somewhere between 2 and 3% using PrEP. Al and I were talking about whether this is a promising thing, that some of the yellow bars are going in the right direction, or whether it's all just pretty abysmal. But so you can decide whether half full or half empty. But again, I think illustrating this common theme that we're seeing. So my take on this comes from Dr. Becky, who some of you may have been familiar with during the pandemic, a parenting guru. She says 2 things can be true. You know, you can love your kids and also need a nap. The way I think that this applies here is that we can simultaneously honor that HIV prevention might not be what drives someone coming in the door, or may not be the most immediate need, and also people are maybe interested given the right circumstances. So the question for us all is, what are those circumstances and how can we promote that? So I will we'll next talk about a case. We'll really talk about 2 cases, I think, that illustrate how we are trying to figure out what that right set of circumstances is to promote PrEP use in people who use drugs. So case 1, 42-year-old cis man with stimulant use disorder who's smoking cocaine and methamphetamine, psychosis, and a history of a seizure disorder, who presents to HAP. He was at psych emergency services at San Francisco General for psychosis the day prior, and came into HAP via word of mouth for STI testing. Past medical history is notable for remote TBI complicated by a seizure disorder. He had previously been on phenytoin, is not currently taking it. And with regards to social history, he's street homeless. He actually just moved here from LA last week, and mostly describes sex with women without a barrier method. But he was a bit paranoid during this provider visit and said, "Sex is my business." And so it was a relatively brief conversation. So So next ARS question, and thank you for all being on your toes with these, is, do you imagine you're the provider at this visit? Do you discuss or offer PrEP today? Answer choice A is no, I'm not really appreciating meaningful HIV risk. This is somebody who is smoking their stimulants and primarily describing sex with women. B, no, because there's a lot going on here, and maybe I'll revisit this later practically, but not the time. Or C, yes, let's employ universal education and explore whether he knows what PrEP is and what he's heard about his interests, regardless of risk. Give people a minute. Okay, wonderful. So I love this. People are primarily voting for a universal education approach, and some are reasonably saying, there's a lot going on. Let's revisit this later. I will say that honestly, what I did was B. And we can talk about whether or not that was the right answer. I actually don't think it was, but we'll get into that. But I think that, again, sort of we'll just share the realities of often you're trying to figure out where am I putting my clinical eggs in this basket. But so we'll sort of share that humbly. Results from this visit were notable for positive Hep C antibody, which he had actually had in the hospital, and we were following up with the viral load, so that was positive, and the rest of his testing was negative. And so we went forth and focused on facilitating Hep C treatment for this gentleman. There is a lot here, and I'm not going to go through it for the sake of time, but I just wanted to illustrate. I think this is a sort of common-ish example of what it looks like to get treated, your Hep C treated in HAP. There's sort of a lot of back and forth and a lot of moving parts. I think on the left side, you can see a bit of clinical details with regards to his Hep C, no fibrosis, genotype 1A. He was preferring Glipib or Mavorite for the shorter treatment duration, and said, phenytoin was a long time ago, which would be a drug-drug interaction. And so we had sort of planned for weekly med pickup of Glipib in clinic, given he was street homeless, and then connection to HP case management, which was really fantastic part of our team, and Shanti for navigation. So what essentially ended up happening with our patient was that on week 1 picks up his meds. On week 2, for a variety of reasons, he hadn't started yet, but does take his first day in clinic, has a couple days, loses a few days, comes back to HAP the next few weeks for med pickup, and we have a wonderful case manager who's working with him to incentivize adherence. Hadn't been able to connect to Shanti yet, and then misses another week on week 5, and then on week 6, returns for med pickup and a provider visit. And at this point, as we're sort of looking down the barrel at a little less than a month actually in his body, I'll just remind you of the phenomenal talk that Dr. Hazer and Dr. Briggs gave recently about sort of revisiting missed doses and what we need to do. But sort of this algorithm here is one of our favorites in the HAP room. And sorry, it's a little bit blurry there, but essentially sorting out treatment interruptions. And he was in the camp of interruptions during the first 28 days of therapy and having missed over more than 8 days. His Hep C viral load, as you can see here, was undetectable. And then finally, we were getting closer to the end of treatment, and at the end, essentially week 9, effectively like somewhere around week 8, the patient had an ED visit in which one of the providers represcribed his old phenytoin, which again is a drug-drug interaction. So again, we sort of were like, oh goodness, how much Glipib has this individual gotten in his body? And at the end of the day, what our team decided to do in our weekly case conference was we had a couple of factors related to our incompletely adherent course here. Let's check an SVR4 given some of the sporadic engagement, and then plan for SVR12. I didn't make an ARS question so as not to drive everyone crazy, but I'll say little pearl with regards to Hep C. What is an SVR4? Some of you may be familiar, some of you less so. It's an undetectable Hep C viral load 4 weeks after completing therapy that has a positive, very high positive predictive value for SVR12. It's not in the guidelines yet, and welcome thoughts from our Hep C experts about utility, but particularly for folks in which you are not sure that you'll be able to catch them at week 12. What our approach has been is, can we get an SVR4 and then decide whether we need a 12? So that is one pearl for him. Ultimately, the good news was he did achieve his SVR12. His Hep C viral load was undetectable. And at that visit in which we're sharing that, he asked, can we talk about PrEP? And he disclosed that he also has sex with men and has transactional sex. And so I just want to share that as to come full circle. You all were very much on the train of universal education as an approach to HIV PrEP. But I think something that I see often is, well, they're injecting drugs, but they aren't sharing their supplies. So do we need to bring up PrEP? Or we aren't getting a sexual history that is really at high risk. We're making us most worried about HIV risk. And so just a reminder that the ISUSA and CDC guidelines are essentially promote this strategy of universal education, discussing and offering PrEP to all sexually active persons. And then I won't read everything that is here in the yellow, but again, really, this is an approach that has been incredibly valuable and helpful. I think we've seen the utility of in HAP of sharing more about PrEP, really trying to target, again, in thinking about that PrEP cascade and people who inject drugs that I shared in the beginning. We know we have an education problem. So that's one place to target. And I think something that happens often with our population is and the reason why this is a recommendation is that reporting behaviors that are associated with HIV risk are not always what someone's going to do when they walk in the door. And so his transactional sex was not something that he disclosed to me on day one. But now, we're here a couple months later, and he clearly does have HIV risk. So he was started on CAB-LA and remains on Q8-week CAB. And I think, again, it's just a good reminder of this universal education approach. So with that, I will turn it over to Al to talk about case 2, and we'll sort of hop between each other. And last reminder from Anika is that if you missed this slide to claim CME credit, you can go forth.
Great. Okay, so our case 2 is a 19-year-old man who has a history of depression, anxiety, ADHD, and also reports alcohol and cannabis use. He was actually referred by his pediatrician to the HAP for a PrEP start. This was about a year ago. Of note, he was on his parental insurance, Medi-Cal, so he really didn't want his parents to know that he was taking PrEP. And his pediatrician had actually tried to prescribe Truvada, but he had trouble navigating the pharmacy prescriptions and getting refills. So when he came into HAP, we discussed options, and he was really interested in long acting. So we started CAB-LA. He completed his 1-month loading dose, but then subsequently missed several maintenance injections. And there was a trial of bridging with daily oral TDF-FTC, but some suboptimal adherence. So he comes back to the clinic, reports 20 male partners in the last 3 months. His last sex was last night. He reports bottoming and topping with his primary partner without a condom. And so, he's here for injection. His last injection was 15 weeks ago, so he's 7 weeks late. And his next dose is actually, thanks to our amazing pharmacist, was in the clinic. So the next audience response question is, you draw the blabs, including an antigen antibody and an RNA. And the question is, what would you offer him at this time? A, CAB-LA today and reload at 1 month, then every 2 months. CAB-LA today and just resume every 2 months. Given that he had a recent exposure, would you do C with big TAF FTC for PEP for 28 days and then restart his CAB-LA? Or would you actually restart his CAB-LA and also offer big TAF FTC for PEP for 28 days? And we'll see what folks are thinking. Okay, so we have a mix here. It looks like it's shifting. And so we have a little less than half who are choosing the PEP option, either C or D. And then some folks are saying the A choice as well. So I'll just talk through each of these choices. In terms of A versus B, given that he's more than 4 weeks late with his injection, A would be the correct option in that case to reload with the 1 month. The recommendation is to reload with the 1 month dose. And then C versus D, I think it's definitely reasonable to talk about PEP, given that he was late for his injection. He had a recent exposure. I will say that in the HPTN 0883 study, we actually didn't reload until people were 8 weeks late. So he may still have some protective levels, but I think it's definitely reasonable to talk about PEP. And then in terms of the options, I think we're a little bit in the data-free zone. We don't have data for CAB or LN or even CAB-RIL for as a PEP option. So I think either C or D could be an option. He was reporting difficulty with taking daily pills. And so I think some people could convince themselves to make the option of D to offer CAB-LA as well as big TAF FTC, but I think either option is reasonable. So we also wanted to delve a little bit more into social and psych history just to understand this some of the pattern of missing doses. And so he actually reports he's attending school in Southern California and is actually traveling back and forth from here. And which may be contributing to his missed injections. And when he's here in the city, he's living with his parents, but it's a really chaotic family environment. His parents are not supportive of him being gay. And so at times he's actually marginally housed. In terms of psych history, he reported increased depression after coming out to his family. And also along the ADH lines, he reports a long history of difficulty with focus, with attention, and also completing tasks. So I think it's great to take a step back and just think about some of the specific challenges that transitional age youth may face, which may impact their persistence on injectable PrEP. So here are some domains to consider for developmental. These youth are still in their transition to independence, and so they may not have established their routines, and many of them may not have experience managing appointments, going to the pharmacy, and so this could contribute to some missed visits. In terms of cognitive mental health considerations, his ADHD could contribute to some executive dysfunction, and depression, anxiety may lead to isolation or avoidance. And so this could lead to difficulty scheduling appointments and tracking when he needs to come in. Also important to think about some structural factors, both work and school conflicts, transportation barriers to get to the clinic, and then insurance considerations. A lot of youth are on their parental insurance and may not want their parents to know that they're taking PrEP, where they may be changing insurance. And so that can definitely be a barrier. And then housing instability as well. And so all of these can be competing priorities and impacting their attendance in the clinic. Also some social and relational factors like stigma, disclosing, concerns about disclosure. We have a number of patients that have a lot of concerns around other people finding out about their PrEP use. And then also shifting partner networks can lead to variable risk perception and reduced motivation to stay on PrEP. Substance use can also contribute to disrupted routines, which can lead to inconsistent follow-up. And finally, our health system, we may not have youth-friendly spaces or that offer flexible hours, which can also contribute to disengagement. So considering some of those barriers, these were some of the strategies that were tried to to mitigate some of those factors. So the patient started seeing behavioral health and psychiatry, was actually started on escitalopram and methylphenidate for depression and anxiety, and his ADHD, and actually felt some improvement on these medications. Also engaged in some psychotherapy through a school-based program and found that helpful to deal with some of the family issues. Our amazing nurse, Christy, provided a lot of education and support with how to navigate the healthcare system and go to the pharmacy and get pick up medications. And we also routinely outreach with text reminders for their visits. And with the drop-in model, people can come in anytime during open clinic hours. However, given these strategies, there were still, with his competing priorities, he was still saying he was having trouble coming in every 2 months to get his injections. And he had actually heard about from our nurse that there's a 6-month option for PrEP coming up. And so he actually wanted more information about that. So I just wanted to take a few minutes to compare CAB-LA versus LEN, which is really an exciting option we have now for PrEP. It was approved in June of this year for prevention. So first of all, CAB-LA, we know it's an integrase strand transfer inhibitor. It's a single 3 milliliter intramuscular injection that's given gluteally, either ventrogluteal or dorsal gluteal. There is a 1-month loading dose, then dosing every 2 months, so about six injections per year. Injection site reactions are the most common side effect, but they do improve with subsequent injections. For LEN, it's a capsid inhibitor. It's 2 1.5 milliliter subcutaneous injections, and these can be given primarily in the abdomen or thigh, but also upper arm or buttock or other alternate injection sites. These are given every 6 months, but there is a loading dose for 2 tablets on day 1 and 2 tablets on day 2. So it's 2 injections per year. Also, injection site reactions are common. And with LEN, you can also get nodules, which are essentially the drug that's kind of releasing over time. And so 2/3 of patients can develop nodules, and these can actually last on average about 6 or 10 months. For both of these regimens, icing before and or after the injection can really help with pain management. And both of these regimens are quite costly out of pocket, but they are covered under Medi-Cal, and also there's medication assistance programs available for both. We did, similar to CAB-LA, we've developed an insurance flow sheet to help navigate the complex pathways for getting people access to LEN for PrEP. And so we have strategies for people who are uninsured or underinsured, Medi-Cal, which is pretty straightforward. And then private insurance is a little bit more complicated, but the field reimbursement managers are really helpful in working through these issues. So you talk about these 2 issues with your patient, and he's actually really interested in LEN, but he is really concerned about the nodules. He's very slim and was concerned that they would be noticeable. So he said he wants to think more about it. But he does ask, how are MISC injections handled for LEN, and how's that different for CAB-LA, and whether there are any interactions between LEN and recreational drugs. So the next question is, which of the following approaches is recommended for missed LEN doses? A, if a patient misses a second oral loading dose, advise them that they no longer need to take it if it's 2 weeks after their initial injection. B, if a 6-month injection is to be missed, offer them weekly oral LEN at 300 milligrams a week for up to 6 months until the injections are resumed. C, if a 6-month injection is to be missed, offer weekly oral LEN at 600 milligrams for up to 6 months until injections are resumed. And D, restart initiation dosing, which is both the injections and the pills, if the injections are over 4 weeks late. See what people are saying here. So the majority are saying D. However, the correct option is actually B. You can give oral len 300 milligrams for up to 6 months, and we'll talk through this. This graph is simulated len concentrations during the first 4 weeks, and it's with or without oral loading. So the blue curve is with the day 1 and day 2 loading, and then the green curve is without the oral loading. And you can see the red dashed line is the IQ4, which is the inhibitory quotient 4, which is the concentration that's 4 times, at least 4-fold greater than the in vitro protein adjusted effective concentration, which is sort of a target, PK target. It's 15.5 nanograms per mil. So you want to be above that line. So you can see with the oral dosing, you get above that line really quickly, and certainly by the second dose. Whereas if you don't do the oral loading, you can see it really takes some time. And on average, it's about by day 22, do you finally get above that line. So in terms of the recommendations around missed len doses, if they miss their second oral dose, which we are concerned about in HAP because it does involve people having to take a dose, an observed dose, that you want to take it as soon as possible. And it could be up to day 22 when they reach their levels. There is a recommendation not to take 2 tablets on the same day. In terms of delayed injections, so if they're over 2 weeks late, then, and it's a schedule, if people are anticipating that they're going to be delayed, you can prescribe 1 300 milligram oral tablet taken once a week for up to 6 months until you resume the injections. And you can just restart the injection dosing without reloading as long as it's given within 1 week of the last oral dose. So the oral dose kind of keeps your level up so you don't need to reload. However, if they do miss the injection by more than 28 weeks, I'm sorry, if the duration is more than 28 weeks since your last injection or more than 2 weeks late, then you do want to restart the initiation dosing, both injection and pills. So there's a pretty short window of 2 weeks for that. And for this last question, I'm going to pass it over to Ayesha.
Thank you, Al. So our patient also was asking about potential interactions between non-prescribed substances and our 6-month PrEP option of len. So which of the following non-prescribed drugs has a possible interaction that you know of? Is it A, fentanyl, B, alprazolam, C, ketamine, or D, cannabis? I'm going to be kind of fast so we get through everything. This was not fair because I made you pick one option, and in reality, there is potential for an interaction in all of the above, but I would still prescribe len in the context of the substance use. And so let's talk about what we know and what we don't know. And I'll just say at the outset that this is a topic that we are sort of early in. I think still a lot more to learn. So as a mechanistic reminder, lenacapavir is a moderate inhibitor of CYP3A4. And what that means is essentially you have the review, I know for all of you, you have your substrate drug. So in our case, we were thinking about various substances, right? Like fentanyl, ketamine, et cetera. And then there is metabolism via our cytochrome P450 system. And we're particularly focused on CYP3A4 currently, that is processing that substrate into a metabolite. Len is an inhibitor. So as that CYP3A4 essentially slows down, you'd expect higher concentrations of that substrate drug. So a natural question is, what substances are substrates of 3A4 and what are not, and how does that help us ascertain what might be a drug interaction? So that's sort of step one. So 3A4 substrates that could be affected by len include benzodiazepines, including alprazolam, midazolam, bromazolam, which we'll talk about as a clinically important one, Midazolam was in sort of phase 1 studies, a dose of midazolam as a substrate was both the AUC and Cmax went up by between 2 and 4-fold after a dose of lenacapavir. Cocaine, fentanyl, which we'll talk about more in a moment, ketamine and cannabis, again, are all 3A4 substrates. Something that makes this, while I have this sort of diagram up here, I'll just sort of share something that makes it more complicated as well. There are a number of things. This, I'm showing you one metabolic pathway. All of these substances and our drugs, both prescribed and non-prescribed, may be metabolized, and most are, through multiple pathways. So let's take the example of fentanyl in that, and I know everybody is concerned about let's make sure we're not doing anything that's worsening an overdose crisis. Fentanyl is metabolized via multiple pathways, not just CYP3A4. So how does this inhibition, is there sort of any compensatory metabolism in any of those pathways? How does that result in changes in concentration? What about, we talked about sort of that increasing concentration of the drug, but our metabolite of fentanyl, norfentanyl, is a common we think about, is actually an active metabolite also. So how much does it matter? There are a number of sort of these clinical questions that really make, I think, determining clinical outcomes from pathophysiology complicated. So we'll leave it at that. Substances that are not a major substrate of CYP3A4 or P-glycoprotein, which is this sort of other metabolic pathway by which len is inhibiting, include alcohol, methamphetamine, MDMA, psilocybin, and GHB. I'll say about methamphetamine because some people might be like, wait, don't we think about methamphetamine and cobicistat sometimes? Methamphetamine is primarily metabolized by CYP2D6. There is some small 3A4 activity. So we could debate where I should put this in these two tables, but that's why I'm putting it on that side. And then GHB metabolism is, there's also much that is unknown, but we does not appear to be 3A4 metabolized. So I think one way that something that I think we as both HIV and addiction and sort of medicine providers should think about is in San Francisco, what are the top substances leading to death? And then how do I think about what might be a drug interaction or what I should pay attention to? And so Dr. Philip Coffin and the Center for Substance Use and Health have an EPI report that they publish once a year that look at the number of substance-related deaths in the city and ascribing number of deaths to each substance. And these are not mutually exclusive. But I think that, again, what you can see here is that fentanyl is really driving the majority of overdose deaths. And so that is a substance that I'd say I would pay attention to here. We know that both stimulants, so methamphetamine and cocaine, are involved in many overdose deaths, but the pathophysiology is, again, in sort of those deaths in which there's fentanyl and stimulant are really mediated by fentanyl. So again, sort of I'm primarily focusing on fentanyl. And then, there are smaller numbers here, but benzo plus fentanyl is another scenario in which we know that co-use is associated with higher rates of overdose. So that's sort of another combination I'm thinking about. One thing that I would say that is a reassuring note is that cobicistat, a drug that we are all very used to using, is a potent CYP3A4 inhibitor, while len is moderate. So how are we addressing or not addressing any of similar drug interactions, and can we infer patterns, when we are prescribing boosted darunavir to our len experience? I think that is something that has made me feel better while we await more data. Overall, I'd say that a few things I'm very interested in to follow. One is following updated Gilead data that'll be presented at ID Week next week. That is, I think, diving into more of a PK modeling of the relationship between fentanyl and len. And I'd say more than that, even the thing I'm sort of indexing for in greatest fashion are the Purpose 4 results, because I think that clinical data from participants will be incredibly valuable. Their Purpose 4 is not excluding participants if, say, they use fentanyl or benzos or anything. And so I think we will be able to get those data. And one, again, complicating factor that I would note when interpreting a modeling study versus, again, looking at clinical data is that often, the best we can do is looking at IV fentanyl, that's medical grade. But to share with you all, part of the reason why our numbers fluctuate in this ongoing overdose crisis is that the potency of street fentanyl can vary by orders of magnitude week to week. And so what people are contending with on the street can really go up and down. And so that makes it's the opposite of a controlled environment, right? There was one other thing I was going to say along those lines, but I've lost it. So anywho, I think that again, those clinical data will be very helpful. Okay, so after further discussion, our patient would like to restart Cab-LA for now. So he is again still thinking about len, and that will be on the docket. With our last sort of 15 minutes or so, Al and I wanted to share some quantitative data and some qualitative data with you around, as I mentioned in the beginning, sort of how we're thinking about welcoming people into PrEP care for people who use drugs, and how we're refining this model of care. One question that we had is, we have started a reasonable number of people on PrEP. We'll talk about these actually quantitative data, but 84 people on cabotegravir. And so the one sort of natural follow-up question is, why did they come in? What led them to walk in the door, and how can we optimize these things? And in an analysis that was really led by Christy Camp, you can see this pie chart of essentially what in this retrospective look at what made people walk through the door. And again, this is at a time when we had 69 people prescribed PrEP. Proportions are listed here, but the greatest reason for referral to HAP that were noted in the chart were peer or partner referral or word of mouth. Second was referral from primary care, so supporting the rest of the network. Third was an encounter for safer use supplies. And then you can see the rest of the proportion. As we'll talk about, we do have incentives for STI testing, including HIV, that are sort of underlying all of this. So I think that is a factor that's not listed here. And then with regards to quantitative outcomes, as I mentioned, 84 people have been prescribed cabotegravir between August 2023 and June of 2025. And that proportion represents 20% of the patients that we have seen, 20% of our HIV negative patients. So one thing, I think that just to reflect on that number, that is just something that I'm really proud of for our whole clinic, our whole group, in that that's a very different number than the 4% number we talked about in the beginning of the talk. So again, I think that really drove why are people coming in, and how do we keep them with us? Just to also share that, the number of new diagnoses in HAP, there are a couple of people that these weren't all, some were referred in for new diagnosis. Some were identified in HAP, but were 4 in the past year, again, out of a relatively small number that we see in the city, around 30. So just emphasizing that these are the patients we want to be seeing and we want to have in care. With regards to continuum, our data are, so of those 84 prescribed, 72 initiated CAB. So we have sort of 12 people that did not return for their initiation dose. Most of those completed their loading 1 month apart. And then this figure is a bit misleading, but I'll take you through the numbers. Of the people that we have enough follow-up data for, which is 57 people, 50 were retained at 6 months. I will say when looking at this, I thought, oh, wow, that's 88% retained at 6 months. That feels pretty good for this population. And I do feel that it is, but stay tuned. Don't want to, what we've submitted something to CROI is sort of a bit more of a nuanced analysis around biomedical prevention time by housing status. And I'll say that our median biomedical prevention time in our group overall was 10 months. So yes, we're getting to 6 months, but how do we actually get people to a year or longer? And what are factors there? I will turn it over to Al to talk about the qualitative.
Great. So we wanted to supplement the quantitative data with some feedback from clients and staff on what could we really be doing, what's working in the clinic and what could we be doing better. So we applied and got funding from Gilead, one of their NOVA grants, to do some qualitative work with both patients. So we interviewed 15 patients and 7 staff, asking about the barriers and facilitators to care, and as well as how can we increase PrEP engagement within the clinic. So in terms of the patient interviews, 11 were in English, 4 were in Spanish. The median age was 38. About 3/4 were cisgender men, 26% were cisgender women, a third were Latin and 14% African American. And as a testament to the high interest in injectable PrEP, 88% were currently on injectable PrEP, 6% were on daily PrEP, and 6% were not on PrEP. Of the staff interviews, we did 4 nurse interviews and 3 patient navigator interviews from our partners at Glide. So we first asked about what were barriers to engaging in care, either at the HAP or other clinics. And not surprisingly, we heard about a lot of competing priorities, including housing, food, lack of rest or sleep. Transportation to the clinic was a big barrier, as well as mental health, state of mind, as well, and disabilities. So I'm really excited. Ideally we would have a panel of our patients here, but the next best thing is to hear from their voices directly. So one patient said, a 45-year-old cisgender man, I've had chronic disabilities, numerous different ones for a long time, and they've told me just suck it up or tell you they can't help you. It definitely got in the way with my work life, relationship life, just period, just even quality of life. I'm definitely just trying to get the help to be healthy and improve. And a 35-year-old woman, cisgender woman, said, I've had a couple of times I was late to the methadone clinic because I missed the bus by 4 minutes. I should have been more on top of taking the bus before that. I'm still trying. I'm not from here, so I'm still trying to get used to the bus system. Other barriers to care were just not even knowing about existing services. And then also not having a place to leave their belongings and not wanting to leave them unattended. And this is related to the uptick of sweeps and belongings being trashed. And then importantly, people also said the inability to bring their pets to clinic can be a barrier. So one participant said, I think maybe people not being aware about resources related to HIV prevention care. If I wasn't staying with that person at that time, I would have no idea where to go or what to do. I could have HIV right now, you know what I'm saying? Because I had no idea HAP even existed. And then the Spanish-speaking participant said, there's also misinformation. Like I know that you can go to county health services in some areas, but not everyone knows that. I've had friends who went a year without taking PrEP because they didn't know where to go. So on the flip side, we asked what motivated clients to seek care. And probably the most powerful, resounding thing that we heard was the staff. Having the staff that are relatable, caring, non-judgmental, and compassionate. And we heard from multiple people that compassionate care really motivates their engagement. and that knowing that providers care about them actually inspires them to invest in their personal health. So one person said, oh, cisgender woman, knowing that when I go there, they actually truly care about my health, and it makes me want to care about my health. And another person said, the people are incredible. I like that there's really no judgment. And I like the fact that I've always been honest with my physicians in terms of my drug use. I know a lot of people that don't, and I feel like I really can say anything to any of them, anybody, and not be judged. Other motivators included having free clinical services. The flexibility of facilities was really important. So allowing drop-in visits, no appointments, the afternoon hours was appreciated, as well as less wait times versus the ER urgent care. Having snacks or drinks is another thing that people really appreciated. And just a safe environment where they could bring their belongings, including their pets. And this Spanish-speaking participant said, I personally value my health, and a lot of the medical care that they provide is free. It would be very foolish not to take advantage of that. So we asked people, what are some things that we could do to improve services within the HAP? And so they came up with a number of recommendations. I'm going to share 4 of them here, and then I'll just list a few others. So the first was addressing the lack of awareness of services at the lobby clinic, as well as PrEP. People said the building and location was difficult to find. So they said a flyer would be helpful. Also, using social media, billboards, providing information at locations where they go, information in the emergency room, having their case managers inform them of the services. And as Ayesha pointed out, word of mouth is really powerful. So one participant said, the people that come here, they offer this to their friends or whatever people they hang out with. So one of the actions we've taken as a result of this is that we have worked with we have a designer in our research group who created a lobby flyer that's really tailored around the services that are provided. So you can see this here. We did include a little map so that people know where the clinic and a picture of the building and some of the services that are available. And then the second thing is we're developing this tailored PrEP campaign. We're working with a local activist and artist, Fabiana Rodriguez. And in particular, we wanted to focus on some of the priority populations that have been less aware of PrEP, including cisgender women, people who use drugs, as well as people experiencing homelessness. So this is another one of the pieces of art. So this is sort of a sneak preview. We hope to be launching this very soon. The next recommendation was continuing and actually augmenting the financial incentives. They felt that the incentives were helpful, but they actually recommended $20 to $30 incentives. They felt that it rewarded them for being responsible with their health. And also they suggested having incentives for referring other people to the clinic. One participant said they give gift cards. In those times when I was going through it, it really meant a lot, even like $30. I'd be thinking, how am I going to pay my phone bill today? What am I going to eat? I was living with my friends for a period. Yeah, stuff like that, knowing that people actually care what the essentials are. And then another participant said, referring someone to come in and get tested and get checked. Yeah, I wouldn't mind being part of a refer a friend program, especially when it comes to PrEP and getting a gift card for that. So we've actually, based on some of this feedback and staff input, we've been revising our financial incentive structure. The prior incentive structure was giving $10 to $20 gift cards per month for testing and other positive health behaviors. And so we've increased these incentives to $30 for long-acting PrEP visits and $20 for quarterly testing. We did have some people that were coming in very frequently, so we wanted to, we thought, the incentives work, so we wanted to incentivize what made sense. The third is bolstering transportation support, because this came up a lot in the interviews, and people said they preferred arranged transportation like Uber Health or Lyft, but other forms of transportation were also helpful. And then assistance applying for the annual transit pass as well. This participant said, once I was staying with a friend all the way in Santa Rosa, and the doctor's office scheduled Uber Health transportation that will take you to any kind of a medical appointment, pick you up and take you right back anywhere. That is cool. It's awesome. So we are exploring new transportation options within the HAP, including Uber Health and Lyft, but we also realize the need to come up with some guidelines on who would be appropriate for this, and also a staffing plan for actually implementing it. And then one of the final recommendations was expanding case manager, social work, and mental health services. And they felt that connecting people to housing, food, and mental health resources was really important. Clients had really differing levels of awareness of these services, so better advertising them would be helpful. One participant said, the social worker here actually helped me get housing, and they first helped me get into shelter after the assault, so I wasn't on the street. And then a little while later, they helped me get into a temporary room. So along these lines, we're really excited that we have our psychiatrist, Dr. Molly Burke, who is available with Psych Fellows to help us with cases via consultation. We have case management services working with Alliance Health Project. And while we don't have a dedicated social worker, we're seeking additional funds for that service. These are some other recommendations that people came up with, including expanded clinic hours, bringing services out into the street with like a mobile clinic or mobile van, expanding wound care, as well as shower and laundry services. And then also lost phones is really a big issue, especially for tracking people down. So trying to think about how to address that. And finally, holistic community building, such as Afrocentric cooking classes. So Aisha's gonna finish this off.
Thanks, Al. Okay, so we talked about many things, but in conclusion, HAP is a low barrier clinic focused on HIV prevention treatment, Hep C and STI treatment, as well as harm reduction and substance use disorder treatment for people who use drugs and people experiencing homelessness. Come visit us any afternoon. I think that one concept we talked about in the beginning is sort of navigating this tension between competing priorities and how to create structural support to make PrEP an important piece of the sort of clinical problems. And one strategy is use of universal education. Others include sort of the structural changes that Al described that are listed at the bottom here. And then with regards to long-acting injectable PrEP, we talked about a few things, sort of comparison of CAB-LA versus LEN, a bit on drug-drug interactions, though I'll share that I believe Janet Gorchaski will be back during the series to talk about this more. And really, ultimately, I think we are really thankful to work with such an incredible, caring, compassionate, and non-judgmental team. There are a lot of people to thank, but really, Mary Shields, Jan Oscarson, Monica Gandhi, having sort of been the brain children of HAP, and then Christy Camp being the heart and soul of HAP from the very beginning, and of course Nagin Cesar, all of the HAP providers, our addiction medicine fellows that spend time with us, and really everybody else on the slide. So thank you all so much, and we may not have a ton of time for questions, but we're happy to be here as needed. Yeah.
Thank you both so much. That was fantastic. We have 2 minutes, so we'll take a few questions from the audience. In the back.
That was an amazing talk. Thank you so much. I feel very inspired. First of all, I'm also a child psychiatrist, so happy to do some consultation with my engagement. Okay. And regarding your teenager, I don't know if that's a real case or a make-believe case, but remember the big drug interaction for that age is SSRIs and MDMA and other psychedelics that can end up with serotonin syndrome. Also at that age, it's a great time to engage in therapy. Somebody from a chaotic household step in and help them
Thank you so much, Dr. Berg. It's fantastic. I think that I really liked how Al highlighted the challenges that are transitional age youth, which is new to me. I think we were talking about this with Christy the other day. Having, yes, someone who's approaching so many things, not of course just the chaotic family environment and substance use, et cetera, but also, yes, never having gone to a pharmacy or made a scheduled appointment before. Things like that are a lot of additive barriers. I agree, and with my addiction hat on, completely agree around the role for prevention in this population around substance use, and sort of can we address it before it is a use disorder is an important consideration.
Oh, yeah. We'll go to you and then.
Good. Thanks so much for the talk. I was just really curious when you were mentioning the folks who were not retained in care, like what the predominant challenges was. It injection site reactions, or people were lost to follow up entirely, or people were switching to oral, or yeah.
Ooh, really good question. A mix, very few switching to oral well, largely people that were essentially just lost to follow up, that were street homeless, with substance use disorders, sometimes seen in other spots, infrequently like MXM, et cetera, but just hard to contact. A couple of people were receiving texts or in the system, but just were not responsive, and so hard to know whether they had just decided this was lower priority, or whether it was really the other competing priorities. Great question.
This is more, well, just congratulations. This is so amazing to everybody on this team. Incentives are really important. Like, there's so many things that you shared that are necessary, not sufficient. And that one study, do you remember, I think it was published in JAMA, they gave huge incentives and it didn't do anything when they presented it, then they changed it in the final paper, but it didn't make a big difference. And it was a huge amount of money. So I think identifying what's the sweet spot, how do we tailor, model it out so we get the funding for it? Because we all know it's critical. Yeah. So that's just more of a compliment and a comment.
Yeah, thank you so much. It's such a fantastic point and comment. This, as someone who thinks a lot about contingency management as one incentive-based intervention in the world of behavioral economics, it's incredible things that had to earlier days of HAP, we were $10 for someone getting their HIV test. Great, you get a gift card when you get your test. And then you have a positive and they're not back. And so we had to shift to, oh, you get your gift card at time of result. And so I think you incentivize, Paula Lum has said this to me before, you really get what you incentivize. And so you have to keep shifting around what is it that you are really targeting. And I think that those data HIV viral load that they got 2 weeks ago, but it was very nebulous. And so figuring out how to really be as specific as possible.
Okay. Okay, we'll do one question and then we'll wrap up.
I'm interested in your thoughts on this fantastic talk. It's great work to all of you who work in the clinical. Our numbers for patients this year, the people with new diagnoses, very small numbers, but I was really astounded that for the first time this year, well over 90% of folks with new diagnoses are Latinx or Black African American, 70% Latinx. And so obviously failures of prevention. And I'm wondering your thoughts on just sort of expanding prevention services to these populations.
Yeah, no, I think that's a really important point. And I think within Getting to Zero in our PEP group, we're really trying to focus on those populations in terms of what we can do to both increase awareness as well as multiple access points to where folks can engage with prevention, and working with peers, working with just community ambassadors, and just trying to really get the word out. So I think that's a really important highlight.
Thank you all so much. That was fantastic. Thank you again.